So the whole goal of this is to get you metabolically healthy, right? Metabolism and the endocrine world are two of these things that people are like, oh, there's a specialist for that. But everything in our body works off the endocrine system and metabolism, right? Like even when you're sleeping, your metabolism is working to keep you alive. So if we don't view that as the most important thing right now, which is what I do, I think we're off base on almost all illnesses. We really need to get our foundational metabolic function, use of sugar, use of protein, use of fat, super efficient, or that's how we become unhealthy.
Well, welcome to the show. And it is a real pleasure to have Marko Lujic on the show today. How are you?
I'm doing very well. Thanks for having me.
Did I say your last name right?
You did. So, I mean, the appropriate pronunciation is Lujic, but I do
Lujic.
like Lujic,
Lujic. I like that. Should I
the
ask you?
Balkan version.
I've heard different pronunciations on different podcasts with you, so I will remember this for next time. So I'm excited to have this talk with you. I met you through our mutual friend and podcast host, Jody Harrison Bauer. She's got
Yep.
the Authentically Fearless podcast. She's interviewed us several times. You guys talk a lot about hormone therapy because you're treating her through her hormone therapy, and she's in an incredible shape. She's in her
Yep.
60s, such an inspiration. Whatever you're doing with her, it's friggin' working. And she is, in case people don't know who she is, we've done an episode with her too. She's a into bodybuilding champion, and she started competing when she was literally like in the middle of her menopause transition. So she
Yeah.
shows us all that it's just like honestly never too late. And menopause can and should be the best years of our lives, right?
Absolutely. It's never too late to feel good.
You've got a really fabulous background in medicine, but also in athletics and fitness. That's such a rare find in a doctor. We covered hormones extensively on this podcast, but I think with your background and your knowledge, I think we should take a deeper dive into testosterone and
Sure.
how women in midlife can overcome some of these challenges that we're having building muscle. But before we do this, I want to know why you got into this world of hormone therapy for menopause and
Yeah.
women after dedicating your life as a general surgeon.
Yeah, so it's interesting. I mean, I started in the regular traditional medical field and did residency, general surgery residency, matriculated through that, became an attending, was working, doing lots of operations and busy. And I kind of started just noticing, I wouldn't say call it disparities in healthcare in terms of bigger group subsets, but just disparities in terms of how we treated even each individual in amongst women, amongst men, amongst children, whatever. And I just started realizing like we could do so much more in terms of prevention so that we can avoid the situations people were in when they got to me. And instead of reaping the benefits in my mind of people's sickness, that's where I came into play and made money off that. I figured it might be nicer if it's a win-win for both people, right? Like I could make a living off helping other people avoid going to a hospital. And the natural trend in that thought was to go into primary care, right? Because the version of primary care that's advertised to the consumer in the modern era is one of quote unquote prevention. We'll try to watch you so that you progress through life without any ailments. But really, it's one of waiting until something breaks. So I started to see these little errors in what I thought was preventative care, and I really wanted to get into true how do we avoid illness? And it just naturally trended and trended and trended. And then I saw this hormone therapy world starting to explore stopping the aging process. So maybe not having the curve turn and go up, but at least having the curve stop and flatten out so that on the back end of your aging, you don't keep getting more and more ill. You kind of stay where you are, see what's foundationally wrong, and we can improve it.
Mhm.
And that natural tendency towards healthcare led me down the road of hormone replacement, led me into the world of men's and women's health. But then I really started to notice the problems with women's health. And it
Mm.
became obvious when I spoke to an OBGYN. I tell this story frequently. And she said to me, you know what, Marko, stay in your lane. And I was like, what do you mean? And she's like, well, you shouldn't be in women's health. And I said, why? And she goes, every postmenopausal woman deserves a little bit of osteoporosis. Ha ha ha. Like a doctor joke, punch you on the side in the locker room where nobody else can hear it. But to me, I was like, interesting. And this was a leader in our area in women's health. And I said, if that is the paradigm of what she's presenting to her colleagues, to her and whatever, even in a joking manner, it's unacceptable. And it kind of gave me even more motivation to try to represent myself as a women's advocate. Now, I know I'm not a female. I've never gone through menopause. I don't have women's hormones in general, the balance of them. But I don't think there's a problem with me being able to empathize. And I always said, if you're a doctor, you should be able to treat almost anybody as long as you can understand their story. And that was the second piece of this version of medicine that I really, really enjoy.
Mhm.
It's not just a data set. So if you come to me, I can look on a piece of paper and see one picture, and then I talk to you and I can hear a totally different story relative to why and how we got to where that data set is. And that makes a big difference. And I think the menopausal woman is really the epitome of that interaction because there's so much going on subjective. There's so many feelings, emotions, changes in how women are feeling that if you don't actually listen to their story, you miss a lot of data, which misrepresents sometimes the lab biomarkers that we're looking at, and it doesn't allow you to treat them well. So I really try my best to kind of hear the subjective side of the woman's story, which menopause brings about a ton of subjective things, and then relate that to how we can help them medically.
I'm so happy you got into this world. We need more physicians in general to understand a woman going through menopause. And unfortunately, we are kind of, at least I'm speaking to the through what I'm hearing through my community sometimes, is if you're not a woman female doctor, then it's like, who are you to say what I
Right.
should and shouldn't do? And I don't think it's fair because there's good doctors, bad doctors, male, female, whatever. It's just some bias that I see. So I wanted to hear your background and how you even got this and that interest. But I think it's in that what's most important is that you're listening to the woman, you're helping her, you've got the knowledge, you've got the background. It doesn't really matter, honestly. So
No, and if you think about it, in medicine in general, it's very hard to be exactly like your patient. So even if it's a guy sitting across from me, I'm not him, or for this discussion, I'm not her, but I can surely take the approach to understand what they're feeling and how they're acting. And I do agree with you. It's hard though. The world of medicine is difficult to get people to go into certain fields. And this field is, I think, becoming something that people are realizing is available, but it's very difficult to get people to convert into actually performing this style of medicine. But hopefully we can recruit more in general down the road.
So I'm wondering now, it's interesting your background in athletics and in sports. It seems like based on your website and what I've heard from Jody, you've got it's like a gym slash medical center. It sounds like a dream gym for me.
Yeah, it's awesome. So the concept about 5 years ago, my buddy owns a gym. It's a very boutique, semi-private. It's big. It's 17,000 square feet. It's got a lot of racks and machines and everything. And the way it works is you get private programming, nutrition, and exercise. So about 5, 6 years ago, me and him started talking, and I had my own little healthcare journey, and I got really into healthcare and preventive care around the same time I mentioned before. I started looking into kind of preventive measures to help other people. And we came up with the idea. I was like, how nice would it be to have a exercise facility with a doctor in it, right? Because foundational health is built on making your body better, making your biomarkers better, and movement. We are built to move. So no better place to have, I think, a physician's office than in a place where you're required to move.
Yeah. And you just need like that beauty salon, and then we could get
Yeah,
some of our treatments.
we're working on it. We're working on it.
Like amazing.
Yeah,
So
full
when I'm
coverage.
going back to your background, so you seem like a great person who would understand testosterone. I'm just
Oh
thinking of
yeah.
muscle and bodybuilding and things like that. And just maybe, I don't know if you know about peptides and
Yep.
that whole world. Do you have experience with that just on your own personal basis outside of your medical practice from your history?
Yeah, so the peptide world is a little new. So in terms of consumers, so people don't really know it exists. I became privy to that information around the same time, say 5 or 6 years ago. There's huge advances in that and the use of them. And then the testosterone therapy world, in terms of muscle building and everything, it's deep in the gym world. And it's interesting you bring it up because I think a lot of the quote unquote bodybuilding gym world years ago in the 80s and 90s kind of ruined the public's image of testosterone because people associate testosterone with these other seriously intense anabolic steroids that are used in the veterinary world that bodybuilders converted into human use. Testosterone is not on that level. Testosterone is a naturally occurring substance in everybody's body. So replacement of that is very different than adding something your body doesn't naturally have. And in this environment, especially amongst the women, it's a totally new concept, but being received really well.
Mhm.
And my experience in athletic world, spent my whole life exercising, trying to eat well, working out, building muscle to actually become a better competitor on a field. And the benefits of that were huge. You can play more games, you have better endurance, you have better longevity in the athletic world. You have better interactions with your colleagues the healthier you are, the more in shape you are. So all of those benefits, if we take out of the athletic arena and kind of incorporate it into regular day-to-day life, really help people.
Cool. Okay. So you're the perfect person to ask and talk about muscle and testosterone. So,
Sure.
in case anybody doesn't know, after the age of 30, we lose 1% of our muscle mass each year, and then it accelerates to a whopping 10% just during this menopause transition.
Amazing.
It's crazy. Is it our hormones? Is it age related? Is it because we're more sedentary? Are we training and
Yeah.
eating wrong? Like, what's going on?
So I think it's actually multivariable. I think the base, so if you looked at the biomarker base in the human body, it is probably a slight decrease in hormones, right? Especially in women, which clearly get to a point where they almost abruptly shut off, called menopause. And even in men, so in both those populations, hormones start going down. Now, in women, you lose testosterone, which is already at a lower level than your male counterpart. You start to lose estrogen, your progesterone cycles go off. And then when you get to your menopause, you kind of don't have the emotional drive that you once had because the chemicals that were in your body are now not there. So that, in my mind, is the start. And then it somewhat snowballs, right? You get a little older, maybe you have kids, maybe you have a job that's a huge requirement of time, right? As modern society has progressed, women have become way more engaged in the 9 to 5 world, right? So now you have women that are stressed with regular life, working a full-time job, trying to get to bed early, trying to get up, trying to do all these things. Time for gym usually is on the back burner. So now you have that third variable, right? So you don't feel so great, your hormones are shutting down, maybe a little less motivated. Now you stop wanting to go to the gym. Maybe you don't eat right. Life is distracting, so many easy foods to get, and it just kind of tumbles. The true muscle mass loss, if we were to pull one lever and blame it on something, is most likely inactivity. But without hormone balance, even the right amount of activity might not still get you to the place you want to go. So it kind of requires the big levers getting pulled and then the little levers getting manipulated so that we can make that big lever work.
This reminds me of one of my courses in gerontology, and it was on the physiology of aging, and
Yeah.
sarcopenia came up. And the professor stood up and he's like, I'm calling BS. It's not age related. We're just sitting on our butts.
Yeah.
I was like, oh, I thought I was expecting
Yeah. Yeah. Something drastic.
biological change, like something clicks. And he's like,
Right.
no.
Yeah.
So, yeah, I think that's a big driver. And of course, there's a lot of, you said, there's all these other factors. But if you guess if you pick one lever, yeah, because you can see people who are staying active, they seem to be able to hold on to their muscle mass and going against all odds.
Right.
Now, is it harder? Probably, right? Now, without, especially for women without our estrogen and our hormones,
Yeah.
it's, yeah, it just gets harder. So we know we should be moving on. We should be building muscle. Like we hear this
Yeah.
all the time, lift heavy, build muscle. But what, in your opinion, is a good amount of muscle for a woman to have in midlife? And like, how does she know or measure that?
So if you were to look, I mean, the tried and true baseline is what's called a DEXA scan, DEXA, and it'll give you muscle mass, fat mass, bone density. The appropriate, that's the appropriate assessment tool. The appropriate number is not so much a BMI or a whole number, or you should have 60 pounds of muscle and this and that. It's more percentage. And the ideal percentage is somewhere between 18 and 20-ish% body fat, where you see the best reward in terms of being well nourished, right? Because you don't want to be too lean. That's not healthy either. You don't want to live at a body fat percentage of like 9%. That's not good. 18 to 20-ish, where you have the most amount of reserve. Calorically, you have a little bit of play room, right? You might gain a pound a day, you might lose a pound here and there, not a big problem. And at that percentage and that body composition, what I have been seeing anecdotally and data driven is really metabolically healthy people, independent of stage in life. So if you are a woman, like you said, who against all odds in that menopausal phase, in that stage in life where you might not be so motivated to get to the gym or whatever, if you do beat the odds and you maintain that percentage-ish area of body fat makeup, metabolically the results are drastic, right? And the metabolic markers are clear and obvious. Insulin sensitivity and resistance become a huge deal when your body fat percentages get higher than 2022. Muscle mass, use of glucose, use of carbohydrates, all of those things are affected by that body fat percentage, which really it's interesting because we get on a DEXA and it gives us body fat percentage. I think it should give us muscle mass percentage. So instead of body fat percentage, it should say, hey, you're 86% muscle. If that was the calculate, that's kind of my next push with DEXA. I got to discuss with them because I think that's a really good marker, especially for people that are like hooked on the scale. Because as you know, a lot of women and I mean, men sometimes are worse. They're more in the closet about it. They don't want to tell the public, but they're stuck on a number on a scale, right? Like I'm 133 pounds. I live at 126. But independent of that number, if you said, well, you're 93% muscle mass, the number on the scale wouldn't matter because we know you're healthy. And that's the beauty of this. But all in all, the more muscle you can carry percentage wise and then continue to build that whole number, the healthier you will become. And muscles on the human body really, we need to get away from thinking of them as a structural component to us. They are not a structural component. It is a working endocrine organ. It is the powerhouse. It is the engine. It is the physical plant where if you were a nuclear power plant, that's where the nuclear reactor lives, in the muscles. So all nutrition, all energy production, all of it's done there. And I don't know why we like avoid in the real medical world any discussion about that in terms of hospital care because it matters so much.
So 18 to 20% muscle mass. And I'm guessing that's lean muscle mass that
All right, 18 to 20% body fat percentage.
oh, sorry, body fat.
Yeah, that would put us at like 80 to 82% muscle mass if we
Mm,
did the
mhm.
reverse.
80 to 82. And that's what a DEXA would spit out. Or does
Yeah,
DEXA not? But DEXA spits out, I think, kilos, pounds
yeah,
of muscle, no?
DEXA will spit it out in grams. It'll give you bone density, muscle mass, fat mass. Our machine here does visceral fat, the stuff inside your belly.
Yeah.
And it'll give you, mine gives us a calculation in grams, and then I either multiply by 2.2 to give me pounds, or I divide by 454 to give me pounds with a,
Okay. So an ideal fat mass would be 18 to 20%.
yep,
Ideal muscle mass would be 80 to 86% muscle mass.
yep,
For a woman in midlife, that would be an optimal range. And
yes.
so going into a DEXA scan is, I think, is about 100 something dollars to get checked, more or less.
Yeah, around, I mean, for members at our place, we do a little discount. Usually the national average, believe it or not, around 200, $250.
Mm. Oh,
Yeah,
wow. Okay.
they're
That's
not
crazy.
cheap. And I'm in the Northeast, so everything up here is a little bit inflated.
Yeah, I'm in Europe, so it's a little cheaper. I understand that the DEXA can be manipulated, let's say, if you're going eating a lot of carbs or you go in fasted state. And if you went to 2 different days, one eating your like great healthy amount of carbs versus fasted, you'll get two different results. And I think it's when you eat the carbs, then you're going to show more muscle mass.
Yes, and which if I tell people when you do that examination, you want to be almost carb loaded because what that carb load does is those carbs, which are quote unquote sugar, get absorbed by the muscle. They become glycogen stores. They attract a lot of water. So your true like inflated cell of a muscle is at its greatest when you have your carbs completely loaded and you're hydrated. So it gives you kind of that really good set place where your muscle mass should be at, peaked out on food.
Okay, so then that's a really good tip. So if you, the other thing is that I guess if you do go into your DEXA, then you want to do it and you're testing again later on, then you may go, well, you want to do it exactly the same, replicate the same thing next year or the next 6 months or whatever
Yeah.
it is that you do, right?
Yep, that would be ideal. Yeah, because the less variability in environmental exposures to your body at the time of the DEXA is better. So if it's in the morning, not caffeinated, fasted, however you did, you should try to keep it consistent so that those numbers, like you said, don't get changed by dietary intake.
And if I wanted to get a really good muscle mass percentage, then and I wanted to carb
Upload.
load, what does that mean? Carb, like how much should I be?
I don't know how many carbs you require, but the day before that examination, if you ate a half a pound of pasta, you'd probably be pretty carb loaded.
The night before, you mean?
Yeah, yeah, the night before.
Okay, it's not like the morning of eat and then
No, then your stomach will just be bloated. But the night before, if you really fill your reserves.
okay. All right. Let's talk about the other scale ways to measure muscle mass because not everybody can do a DEXA or you do it
Right.
once a year and you want to see more progression. Some people don't like the radiation. We have hacks for that, but
Yep.
what else is that? Can we just use those body composition scales? I know.
Yeah. So the InBody, which is kind of America's version of that, I think it's a global company, but we have them around here a lot. And you get on it, it's got metallic sensors for your feet and metallic sensors for your fingers. And it'll give you a pretty good representation. That machine adjusts even more profoundly to carbohydrate and hydration load, but within 4 to 5% of a DEXA, which DEXA is kind of the baseline foundation. The next thing is, I mean, old school, you get in a water tank test. So they do displacement of water to get your body fat percentage. They have little calipers. Some people grab like the back of your arm, your hips, and your thigh, get a measurement through that. There's a couple different ways to do it, but the best way, if you were to, would be DEXA, those in-body machines, and then beyond that, probably the calipers for the home user would be the easiest way and the least expensive.
Yeah, but you got to be accurate. I mean, you got to be trained, I think, with the
No
calipers.
doubt. Oh,
It's
you have to be. Yeah, I'm just saying if somebody wanted to.
Yeah, if somebody wants, and we're talking about accuracy. But what about these at-home body scales? And we know they're not accurate, but I always say, let's look at trends. Is
That's
that good enough?
I agree with it wholeheartedly. So if that's what you have available, which is a really good piece of machinery, you trend it relative to that, no doubt. But I think that's very useful tool because if the trends are going in the right direction, that's all you really need to follow. Because the whole number sometimes, like we've talked about, doesn't truly matter. It's that percentage.
Yeah, and then we'd have to figure out what's the equivalent of 80% muscle because sometimes these scales, I've got an Omron and they say, well, you've got 36% muscle, is what they
Yeah.
say. Well, that would be very, very low, but I've got pretty good lean muscle mass. But so different scales will have different.
Absolutely different numbers. Like the DEXA will give you a whole number lean mass, right? It'll say 100 pounds of muscle.
Yeah.
The in-body gives what's skeletal muscle mass, SMM, and
Mhm.
that's usually a lower number because it's not total lean mass, it's just they're trying to just interpret pure skeletal muscle, striated muscle. So either way, whatever you use as your foundation to work off, if you keep that consistent and use that as the adjustment basis, I think you're good to go. Like you said, you just follow the trends.
Yeah. Okay. So cool. I'm glad we talked a little bit about that. So we know how much muscle mass is a good amount and at least shoot for that.
Yeah, and strive for it. And metabolic, so the whole goal of this is to get you metabolically healthy, right? Metabolism and the endocrine world are two of these things that people are like, oh, there's a specialist for that. But everything in our body works off the endocrine system and metabolism, right? Like even when you're sleeping, your metabolism is working to keep you alive. So if we don't view that as the most important thing right now, which is what I do, I think we're off base on almost all illnesses. We really need to get our foundational metabolic function, use of sugar, use of protein, use of fat, super efficient, or that's how we become unhealthy.
Absolutely. So let's move on to testosterone. There's some
Yep.
women who take it, some who don't. The medical guidelines say to only give it to a woman to improve her libido. And is that all it's good for? Is like my question. Like I think there's so much, but let's understand a little bit why a woman would want to take testosterone and if she should or shouldn't, and how you know.
So the big thing with testosterone and all of the hormones we need to know is they work on everybody, right? They have an interaction on male, female, and females of all ages. So when you get into the women's world of testosterone, people view it as just a male hormone, but it's not. Women have a measurable level of testosterone throughout their entire life, up to normal amounts around 70 nanograms per deciliter, but even the NIH data shows up to 90-ish is safe. Now, if you've had that much testosterone anywhere in between that range in your body over a period of 40 to 50 years, and then all of a sudden it shuts off, I think logically as humans, if you don't appreciate that that's going to make a change to the body, you're just, I don't know, you're just not seeing the truth, right? If something was there and then it's gone, it has to have a difference in effect. So the libido thing is kind of, to me, one of these instant marketing things, right? So the marketing world for testosterone to women, the easiest sell in the world right now is like sex, drugs, and rock and roll still, right? So if you make something sexy or you make something a little dangerous, that's what people will flock to. So I think the initial push, not from so much the science world directly, probably more from like, how can we make a little money off the science world, was libido. And I'll take it because it actually introduced testosterone to women. And does it help with your libido? It does. But the effects beyond libido are profound. So, androgen receptors, which are essentially ligand dictated protein receptors that are dependent on testosterone to touch it, which then sends testosterone into the cell to interact with the DNA and have your DNA start making things, right? So if you think that's not important, we got a problem, right? At baseline, it's the brain of your cells that's getting affected by the hormones, testosterone being one of them. And it turns on a lot of things in women's bodies. I think the most underappreciated is purely muscle building power. Because what we started out talking about was your muscles as an organ, an endocrine organ, and muscle mass and sarcopenia and all these other things, and a lack of movement. And that is true. If you move more, you should maintain your muscle. But even if you're moving more and you do not have any hormones to tell your body to make more muscle, the connection to making muscle is not there. So if you supply a woman with that testosterone, that gap, and you bridge that delivery system between the exercise and the muscle building, and you make those two work together, the results are profound. So muscle building is a huge deal. Bones. Women's bones become softer when they lose their hormones, estrogen and testosterone together. There are androgen receptors in those tissues that will help you build more bones. And the treatment for women in osteopenia and porosis is hormone replacement. And it's a big deal, estrogen included, but testosterone is a huge deal because not only does it help the bone build itself, but it'll help your muscles, which then can increase your ability to perform resistance training, which puts more stress on your bones, which in turn makes your bones harder, right? So all in all, second thing, third thing actually, mental health. So the brain has huge amounts of androgen receptors, the female brain as well, very responsive to testosterone. So if every cell in your brain has a hormone receptor, we should probably pay attention to it and replace it. And women with testosterone back in their lives usually feel more mood stable, less emotionally labile, and way more grounded in kind of their thoughts and brain fog, as we say it. So metabolically, the impact of testosterone alone on what we just talked about is huge. Now we get into the consequences of what we just said in terms of the building and muscle, making your body kind of more activated towards androgen receptors, turns into you using your carbohydrates better, using your fat better, which then makes you metabolically more healthy, quality and quantity of life instantly increase.
So I learned, did the training with the Institute of Bioidentical Medicine with Dr. David Rosensweet.
Yep.
And I remember him speaking about testosterone. And he says very often, at least in his clinical practice, is that women generally can keep their testosterone in their 50s. Actually, it's kind of like the last thing to go. It's
Yep.
not like progesterone where we start losing in our mid 30s and then estrogen comes along, goes away in our 40s. And then we still, he says, still many women hang on to that testosterone probably about their mid 50s, but eventually it'll tank out when you get your 70s and pretty much zero. I'm wondering, is that accurate or is that not
So
in your practice?
it is accurate. And the interesting thing about that is there are some women who hang on to it. Now, I will take that one step further. Women might hang on to it, but it is definitely decreasing. And I've had pretty much zero women in my clinic that are menopausal that have had testosterone even remotely close to the highest levels. Most of them are in the lower 20%, or honestly, it's zero, like non-detectable,
Mhm.
which is pretty profound, right? Even a speck of it might light up the lab machine, but zero across the board. And those women really suffer. Like it's kind of a very easy person to pick out because they just look quote unquote deflated emotionally and physically. It's a very torturous way to be.
It's interesting because I'm one of these people who, when I tested my hormones for the very first time with a Dutch test, the dried urine test of
Yep.
comprehensive hormones, which it was I was 50 and I still had my regular periods. I just kind of want to know where I'm at.
Yeah.
My testosterone was practically zero. And I couldn't believe it because I build muscle like there's no tomorrow. There's no problem. And
Yeah.
I would have thought I was expecting my testosterone to be way up
Right.
there. But what's going on with people like that?
There's huge variability in each and every female. So there's kind of no predicting factor to say, hey, you're going to hang on to your testosterone longer than the next female. And that perimenopausal phase is very different for all women. So it's not like you enter that phase and testosterone goes down, then progesterone, then estrogen, or estrogen. There's no sequence of events. It's relatively haphazard. And I think the best way I look at it is the ovary just starts like fritzing. It's kind of getting signals. It doesn't know what to spit out. It's a little tired. Doesn't have a lot of follicles. It doesn't make a lot of hormones, but it'll like burst out a bunch once in a while and then kind of retreat. And that happens with the testosterone. So in you, for instance, you might have hung on to a little bit or up until that point, then you went to zero, or you might have been sputtering at the time and at that point in time had zero. But when you got to menopause, did you recheck it at the menopausal phase?
I'm still perimenopausal at
Oh,
54. I just
even
got my
better. So,
period last week and I'm like, wait, I guess this is
oh, that's
extending
good then.
my ovaries.
Yeah, it's something to track, but there's no true way to say, okay, this woman's gonna have less or this woman's gonna have more, or any way to predict who's gonna decline at what rate. But I will tell you, if you are suboptimal, meaning you're not at the upper level of that testosterone range, I'm not talking about outliers. There's outliers to every rule. I'm talking about the majority. Women really like to be at a higher level of normal with their testosterone and overall just feel better.
So there's no conversion. I know that testosterone can convert into estrogen,
Yep.
aromatize into that. So is there any other hormones that convert into testosterone that could have been?
If you look at it, cholesterol turns into what's called pregnenolone. There's a bunch of things that happen in there. Then the transition into the androgen world, meaning the testosterone grouping, is with DHEA, which then will convert into testosterone and might convert into DHT. That pathway links only to estrogen. So really it has to go through that to turn into estrogen. But in terms of the downward slope on that pathway, it's really dictated by cholesterol and the pregnenolone level. So there's no like backdoor entry into that per se. It's pretty much a straight up transition from those cholesterols into the pregnenolone, you know, prostogens kind of world and then into that androgen world. So if that flow is not working well, your testosterone level is just not going to be there.
Yeah. Well, I decided to supplement after I saw that. I was like, okay, I don't want to be surprised. I started
Yeah,
taking.
right. That's exactly right.
let's just go by the data.
Yep.
So you mentioned it was interesting when I heard the podcast that you did with Jody. She mentioned that she was in osteopenia before she met you, and she's been lifting heavy since she was, I don't know, in her 20s or
Yeah.
30s. And
Yep.
it's interesting because every woman I've interviewed so far in her, usually it's a postmenopause phase, who's been exercising all her life has osteopenia or osteoporosis. And I'm like, wait a second. We know that impact, and these are women who lift heavy or doing things like Jody and or exercising or running. It's just to me surprising. Again, this is a small sample of just the women on my podcast. And I thought that's interesting. What is it just that it's not enough? We really do need to supplement with hormones to be able to protect our bones.
Yeah. So if you look at bone formation, you have these things called osteoblasts and osteoclasts. Osteoblasts will build bone, osteoclasts will break it down. Osteoblasts are directly stimulated by testosterone, like direct receptor activity. So it makes sense that if you are depleted in your hormones, you're depleted of osteoblastic activity, that's going to slow down. If we replace it, that should speed back up. And it really does. The other thing is testosterone also is a huge role in osteoclastic slash blastic activity, meaning it helps in bone remodeling. So you will have breakdown and rebuilding. But the hard part of the bone will be made harder, which is the piece you need to defeat osteopenia or porosis, by testosterone therapy.
Well, I've learned, and again, you can correct me, that as the in terms of bone and in terms of even muscle, estrogen is the bigger driver than testosterone.
So estrogen will drive the same bone formation. It'll push more so in women, but the testosterone is also affecting it, right? So they're both going to stimulate similar pathways of bone formation. You just get a better bang for your buck if both are balanced out.
So when you're treating a woman through menopause, do you, because there's so much conversion, I guess, with the hormones, would
Right.
you tend to say, let's get you on estrogen and progesterone first? Or do you do estrogen, progesterone, testosterone as a whole, or does it depend on the women? Because we know
Yeah, so
conversion.
this is actually a good question. I'm glad you brought it up because this is where like the art of medicine comes into play, and it's not purely driven by I need to get you this number, this number, this number. Most most menopausal women, you can start on estrogen, progesterone, and testosterone all at once. Now, the key to this is some women are hypersensitive to estrogen. Some women might have a polyp in their uterus. Some women might develop uterine lining thickening sooner than others. There's two ways to approach it. One, the tried and true method is prior to starting any hormonal therapy, you get a uterine ultrasound and just look at the endometrial strip. It can help you predict what's going on. Second thing is you can start all three. And what you want to do is start the estrogen really, really low. So I am a very conservative practitioner. I can always add to the soup. It's very difficult to take out of the soup once it's mixed. So I usually really start low with my estrogen. I make sure progesterone is dosed appropriately before we raise any estrogen. And then the testosterone I'll tease as the woman starts to feel better. We'll creep those levels up. The reason I do that is some women, like I said at the beginning, are very sensitive to the estrogen, and you don't want to have that breakthrough bleeding. So the
Why
dose,
not? So, because I've interviewed some people who say you do. So why wouldn't
yeah.
you?
So well, there's two schools of thought on that, right? So there's yeah. So this is a little bit of a consumer bias on practitioner take, right? So if we lived in the perfect world, I believe if we recreated a woman's natural cycle throughout time. Like menopause, we gave you back your hormones with ups and downs. You titrated them well in terms of how you administered it throughout your month, and you had your periods back. I think that would be the best version. I think we'll end up getting there with some people that are really, really into this, but that takes a lot of time because you have to maintain every day on a different schedule. But overall, in terms of recreating their health metabolic function, we can do it without recreating their period pretty safely if we have the progesterone kind of always making sure that estrogen doesn't get too high to promote that cycling.
So, is there a marker or a level that we should have our testosterone at, or maybe even estrogen, progesterone, in terms of protecting our bones from osteoporosis?
Yeah, so I don't think there's a perfect level per female. And this is where I really enjoy what I do in terms of using different data sets. Because if I see progression of your bone density in terms of getting better and improving at levels of testosterone that you feel good at, not like, oh, 100 or 120 or free of zero point 0.3, then we'll keep at that level as long as you're feeling good with no side effects, right? But we will keep pushing that until we see those changes. So saying that there's a perfect level to promote bone density is really difficult without seeing the data of the bone density changing. Does that make sense? Because some women feel really good and have really good bone density changes, muscle mass increases at a testosterone level of, say, 45 nanograms per deciliter. And I have some women that are like loving life at 100. Blood pressure is good. Every other biomarker is perfect, and they really like their total there with a free up to about 1.5. So it's hard to tell, but the strategic number for a bone density measurement is not really something that's made available because it's really independent to the female.
This is where biohacking just comes in, right?
Yeah, and it's where this is why I tell people it's difficult to do in modern medicine because you can't do this in 12 minutes a year. I, on average, spend about 6 hours a year with each one of my patients. When is the last time a doctor spent 6 hours with a client? Never. I mean, some of the longest surgeries I did were 5, 6 hours, and that was the longest I spent with them, but they were sleeping, right? But awake in conversation in a doctor's office, that's a lot of time. But it takes that long. And a true medical world to deal with this, like I constantly am interacting with the women I'm treating because I need to know, right? If tonight you wake up tomorrow, you go to bed, you wake up tomorrow and you had a hot flash, or you didn't feel well, or you felt some nausea, or you felt irritability or anxious or itchy, like all of the details actually matter. And the deeper you get into it, the more you realize the details are actually symptoms that we've just given women the palm to the face and been like, it's part of aging, right? Like you shouldn't feel tired. You shouldn't feel anxious. You shouldn't feel exhausted. You shouldn't have soft bones. So I think the time required to do the art of medicine to find for you, Zora specifically, where your bones become best helped with your testosterone level is very different than somebody else. And that just takes time.
Yes, yeah, exactly. That's that way. I just have to take our own N of one experiment and understand it's just nice to have some guidelines or something to shoot for. But in the end, like you said, especially when it comes to hormones, is that we're all so different. And again, it just still depends on your goals. So I tell women, look,
Right.
this is, if you just want to suppress a hot flash, you don't need that much estrogen. You can take whatever. I
Yep.
mean, it takes very little. But if you want to protect your bones,
Right.
then that may need to be a different level. I don't know. And that's again where we test, measure,
Yeah.
assess, and figure that out because the goal, and I'm a gerontologist, so I'm always like, I want to protect my 70-year-old self. And if that's your goal, then
Yeah.
to look at some different levels or have different targets and
Yeah. And
different
I
things.
would say the ideal, so a lot of labs, somewhere between like 40 and 50 nanograms per deciliter is their upper end of normal for women's testosterone. The NIH publishes data around 85 to 90. Most of my women are really happy with really good bone formation, with really good mood, with really good metabolic function around 60s and up to around 80 or 90 with a free, which between 0 and 1.5 is acceptable, around a 1. And
Mhm.
that's for me, if I have a target, I would say a free testosterone in women around 1.
Okay. Yeah. So let's say somebody wants to go and test their testosterone levels. It's not just take my total testosterone. It's
No.
free testosterone, bioavailable. I don't know if you do albumin. What other markers should be looked at?
Yeah, so the biggest thing in hormone world is not is not the total, it's more the free. Another thing is the brain's signals to whatever organ is making those hormones. So your FSH and LH are big indicators of how happy your body is with what it has at time zero. Albumin levels are big, insulin, fasting glucose, lots of different markers to prove to us that your metabolic function is working well, which in turn is an indicator to us that your hormones are properly, to me, that your hormones are properly balanced.
But when you test testosterone, Lisa, when I go into my doctor, he doesn't just give me, he's like, I'm like, why is this such a big bill? It's like, because he's taken
Yeah.
like 4 different tests just to show. And it's usually free testosterone,
Yep.
bioavailable testosterone, total testosterone, SHBG, sex hormone
Yep.
binding globulin.
Yeah. So to answer that question, total testosterone, free testosterone, percentage of free testosterone, SHBG, dihydro DHT levels, I think are very important in women because if aesthetics weren't a thing and hair loss and acne didn't bother anyone, every woman would be on a pile of testosterone. But some hair loss and acne might come with levels higher. So we really need to make sure that the DHT levels are monitored and total. FSH, LH, and like you said, albumin, correct. Yeah, so those biomarkers you have to really consistently check over time to make sure your therapy is working.
Yeah. So it's always balance, I guess, with your symptoms, what you're feeling, as well as
Yes.
then certain levels, and then looking at your goals. So, what about in terms of testing? Is it only blood, or do you test urine or any other ways to?
So I'm a blood testing site in terms of what I use as my base. We do mobile phlebotomy, so for the consumers, it's easy. We send somebody to their house to get their blood, so that's nice. It requires less transport. But I really like the blood markers, and we do them every 3 months. It's part of the deal in terms of being in this system. If you don't do that, I don't want to treat you because I have to know the data. I'm not doing this just throwing stuff at a wall. So the blood tests are what we go with. I think if you're going to do anything, they're all reasonable as long as you use them for what they're worth, right? So if you consistently do, say, a Dutch urine test, fine. If you consistently do, a saliva test, fine. If you consistently do blood testing, fine. It's just hard to do the variability across those. So some people come in here with a past saliva test and they're like, well, this is different than my blood, but it is, right? And we might see differences, and that's okay. We just need to consistently stick to one. And I've found with my clients that are involved in the program, the easiest for me is the blood test and for
Mhm.
them.
You mentioned ideally we'd like to have a free testosterone around one. Is that hold true when we're in our 70s and 80s?
Yeah, I think throughout life, as long as there's no, like I talked about earlier, hair loss or excess aesthetic changes we don't want to see. But yeah, I think all these women that I've so far encountered feel way better when their free testosterone is closer up to that one.
Let's talk about those excess testosterone symptoms. So sometimes they're irreversible, as I understand, like deepening voice or something.
Yeah.
What are those risks of too much testosterone, and are they reversible?
Right. So most of them are reversible. And if you're with a practitioner that is discussing with you on a kind of monthly, daily, weekly basis, you won't really have to worry about them because the minute you have those symptoms start, if you turn down the testosterone, they go away. So it's communication. But the big ones are some hair loss from their head. A lot of women can get along their jawline, especially, but little fuzzy hair, like wisps of hair, mustache hair, just hair on the face. Hair around the site, if they're using a cream application, sometimes the hair around the application site can grow. And then acne is kind of the last piece in that puzzle. Aside from that, the downsides of excess testosterone metabolically are very few without those aesthetic ones. And then the deepening of the voice thing will happen to some women. It is hard to predict, but when it starts to happen, it's usually an indicator to either back off on the dosing or you have to have that discussion with them that, hey, this is going to happen. And then it's a balance. Like, do you care? And if you don't, and we're metabolically happy, I'm okay with it. If you do mind, we'll back off on the testosterone and we'll find a happy balance between that because you have to keep the person happy. And I'm not saying sugarcoat, but they're here because they don't feel good. So I don't want them to feel worse.
Yeah, and I think, as I understand, once you get into that a level deepening of the voice, and it's quite high levels and probably injectable testosterone.
Very
Whereas I
high.
think most women are taking between 1 and 3 milligrams or six. I don't know. What do you?
Right. Yeah, so the dosing I start with is around a 2 to 2.5 milligram dose out of the gate. And I see how people feel. And then we can up it, right? Muscle mass matters, activity levels matter, body comp in terms of fat mass matters. So all of these variables, and then we start dosing. And then what I'll do is slow roll and then hang at a level for a while. Slow roll, hang at a level for a while because you want to give it a couple months, 3 to 4 months at every kind of stage to make sure we're not going to have something bad, hair loss out of the blue or hair growth or deepening of the voice or any of these things we don't want. You don't want to be sideswiped by. So the slow creep. And most of my women are around yeah, 2 to 5-ish milligram per day dosing. And they're very happy. Some women are happy at 2, some at 5, and some people's levels at 5 are the same as another woman's level at 2. So it's hard to tell, and that's where the interaction really plays a part.
And because we don't have, at least in the US and in Northern Europe, FDA approved testosterone for women, sometimes doctors say, oh, just try to squeeze out a teeny tiny, I don't know, 1/8 or
Yeah.
1/16 of a men's dosage, which is ridiculous. Or you go on to a compounding cream. But there are a lot of different ways to take testosterone. So what are the different ways and which ones do you prefer?
Yep. So there's pellets, which are injected or inserted under the skin into the fat of the body and stay there for 3 to 6 months, depending on the provider. 3 months is ideal. There's injections, which can be done multiple times a week, once a week, twice a week, 3 times a week, depending on the person. Those can be into the muscle or into the fat, but that's with a needle, self-administered. Then there's creams, which some are alcohol based, some are water based, some are in like a pump bottle, some are in a click bottle, depending on the type of cream. And those you rub onto hairless or least amount of hair area parts of the body. And that's usually a once or twice a day experience.
I heard
I'm,
there's some sublingual coming out.
yeah, so they've had, yeah, there's sublingual troches, and then there's actually now somebody coming out with a pill. But what I've found is if you look at the dosing, you got to take 8 pills 3 times a day, or yeah, it's crazy. So they haven't perfected it yet. My preferred methods are I'm not a huge fan of pellets. I get where they're coming from, but I'm just not a huge fan, so I don't do that. I'm on the injectable or cream topical application. The most, for me, effective is intramuscular injection, which can give me the easiest way of administration in terms of following the biomarkers in the body, because I think it's the most consistent. The creams, depending on where you put it, depending on your skin, is different than mine, different than your neighbors. So absorption rates are off. You could be a little more oily. You could use a different soap that day. You could, a lot of factors, but the injection is right in the muscle. It's tried and true. You know the dose you're getting, you know the absorption rates, and then you can follow those levels really consistently.
So I know that a lot of women or a lot of human beings don't like injecting, but sometimes the EpiPen type is easier. Is there any testosterone EpiPen type?
Some places will deliver an injectable that's a preset, and you can use it like that into the subcutaneous or intramuscular, but I go with bottle, needle, draw it up and use it. So use for the individual, if they're very needle averse, I think the EpiPen's a wonderful alternative if they can handle that. If they really can't handle needles at all, then I would just go cream.
Yeah. As much as I inject myself, I don't like it. I just feel like a drug addict when I'm
Yeah,
drawing
no, well
stuff out.
that's no, no, but you're right. And listen, Zora, that's like part of the thing we need to deal with, right? It's that even people that are totally into this, they feel weird with a needle. And we got to get over that because if you think about drug administration, there's truly no better way. I mean, use the drug world as something, right? That's an immediate high when people inject drugs. So
Yeah.
if you really want to get the full use of the testosterone, the full use of what you're using, the injections, the easiest method in terms of bioavailability. But you're right, it is an odd thing to do using a needle and in your brain saying to yourself, this is good. Because we grew up in a culture where needles meant bad.
I had to inject myself for 6 months with a drug, pentazine polysulfate for osteoarthritis.
Yeah.
And I got tired of doing it on the belly and I did it on my leg. And now I have this big indentation in my leg.
Hmm.
And I don't know if
Really?
you've seen that. Yeah, yeah. And it's kind of like, in the old days when we had our shot,
Yeah,
our
yeah.
tetanus shot, or whatever it was we had when we were born. And
Smallpox.
yeah, if you're born before the 70s, you have this big old, that's what I got on my leg. And I'm like, I got to reverse this, but it's from an injection. I don't know. You never see
Interesting.
that?
So I don't see that with the hormone injections. With that, maybe whatever was the solvent irritated some of your subcutaneous tissue and caused a little bit of scarring.
Oh,
It has to be. Yeah, that seems more like a scarring issue where that tissue contracting and that skin, instead of being flat, bowed in.
yeah. And that's okay. So that's not a big side effect that you see a lot. It's just once a rare kind of a thing, I guess.
Yeah, some people get a little bruising under their skin. They might have a harder bump under their skin for a little while, but I haven't had any like that yet. But I mean, there's a
Mm.
lot of time left in my life, so I probably won't counter that.
Well, you heard it from me first.
Yeah,
So
yeah. No, this is good to know.
I want to ask you, so you've been treating and training women for the last 15 years or so. What are the three things a woman can start doing today to improve her muscle mass, strength, and power?
Focus on eating protein. We are all underfed, especially women. And in that, I'm going to throw a little asterisk. Please don't be scared of the scale. Do not make the whole number on the scale something you focus on. It's like a prison. It's not supposed to happen. Your total body weight doesn't matter. But if you focus on protein and you gain some muscle or you gain some mass, who cares? Don't look at the scale, but protein, protein, protein. Second thing is movement. So if you moved this amount today, tomorrow just move a little more. Or if you are at maxed amount of movement, continue doing that, right? Movement, movement, movement. It helps the body. We are meant to not be sedentary. Like sitting in this chair right now is probably not where I'm meant to be in life, right? But we have to. We have to work around that. But movement, movement, movement. And the third thing, and I pray, all women should embrace resistance training, meaning lifting weights. Cardiovascular training is great. I'm not saying stop doing that. Running, cycling, walking, whatever you want to do, hit classes, group training, get your heart rate up, great. But a few times a week, 2 or 3 times a week, you have to lift weights. The reason being, unless you put your muscle under tension over time, it will not expand. It will not grow. And please don't be scared of going to the gym and overnight becoming a bodybuilder.
I wish.
That, yeah, no, I mean, like
Not
that takes
easy.
a lot of time and a lot of effort, and it is a full-time job. You will not become bulky overnight, right? But resistance training will be the key once women truly embrace it to kind of advancing this next phase of physical health, I believe. And those three things alone will change because if I said this, the standard statement from most doctors is, well, lose a little weight and move. I don't care that you lose weight. Like we talked about at the start of this, we just need that muscle mass, independent of the weight. Eat your protein, exercise, and then good things happen metabolically.
I love it, Marco. Everyone can find you at rtsct.com. That's your website. The
Yes.
gym slash medical facility slash future salon spa. That's what
Yes.
we'll do.
Well, now we're gonna have to do that. Zora told me to.
Yeah, that's an
And
next
Zora's a
level.
nice, powerful name. If I tell people and they don't know you, they'll be like, "Oh, we got to do that."
Yeah, you call it
Love
Zora.
it. Love it.
I love it. We've got links in the show notes to your email and your website and your Instagram as well. And I
Thank you.
appreciate so much your time and your knowledge and out there helping women build muscle and obviously feeling better. Is there anything else that we missed that you'd like to share before I let you go?
No, I just really want to let the women out there know, like, don't be afraid of a male provider who's on your side. I am here to fight for you. And even though I'm not a woman, I might not know how you feel because I've never experienced it, but I'm more than willing to go to bat for you and help you feel better. And I think you got to, it's tough, right? Because you got to find the right provider, but don't be fearful. We really want to help you. And I think the future's bright once women start embracing this new style of medicine and new approach to preventative care. And I think women like you are inspiring. It's really motivating for me to keep doing what I'm doing, knowing that people like you exist that are really trying to get the word out to improve people's quality of life. That's it. The time we're here, you want to experience it with the most amount of life, the most amount of vigor, and you never want your brain to not be able to get carried around by a failing body. That's the worst thing. Your brain has to travel the world, and you got to have a body to let it do that.
Love it. All right, Marco, have a wonderful day.
Thank you.
And everyone else who's made it to the end, you also have a good day, good night, good morning, wherever you're at. And then we'll see you next time. Take care.
Pleasure. Thanks, Zora.